for the invitation to present the WHO updates on myeloid neoplasms. Of course, my presentation will be based on the review article being published in May on Nature journals, highlighting and summarizing the 5th edition of the World Health Organization classification of hematolymphoid tumors, myeloid, and histiocytic dendritic neoplasms. There is a very nice introduction about how they come up with this 5th edition and how important it is to update the classification every now and then. I'll go directly to the changes on the MPN, MDS, and acute myeloid leukemias and mixed phenotype acute leukemias. First of all, for the cases of MPN neoplasms, you can notice here that they added the juvenile myelomonocytic leukemia under the MPN category when it was in the 4th edition under the MDS MPN, underestimating the role of the MDS in that disease category. There is also changing on the naming of the unclassifiable MPN unclassifiable into MPN NOS. For the CML, there is a major change as they omit the accelerated phase on the 5th edition, and they are emphasizing more into the risk factor of chronic phase that indicate that the patient is going into resistant of TKI or that the patient is progressing into blast phase. So there is no more accelerated phase. And also they updated the criteria for blast phase CML to have more than 20% myeloid blast in the peripheral blood or bone marrow, or presence of extramedullary proliferation of blast, or presence of lymphoblast. However, the cutoff of lymphoblast in the blast phase CML is not that clarify. Hopefully, when they are published the full book, maybe there is more explanation. For other BCR-ABL negative MPN, the major criteria of increased red cell mass being removed from the diagnosis of polycythemia vera. It seems that we are doing a good job in diagnosis of essential thrombocythemia, so there is no change in the diagnosis. For primary myelofibrosis, they stress more in the differentiation between the pre-fibrotic stage and fibrotic stage of primary myelofibrosis, as this have a very big prognostic difference between the two groups. And also they highlight a number of additional mutations that's frequently reported with the cases of MPN and especially primary myelofibrosis, and some of them carry a poor prognostic risk factor. The progression into accelerated phase and plastic phase didn't change. Also for chronic neutrophilic leukemia, the diagnosis is not changed. However, for cases of chronic eosinophilic leukemia, they are now coming with more diagnostic criteria, well-formed diagnostic criteria. They reduced the timing of persistent or sustained hypereosinophilia into 4 weeks only, in comparison to 6 months of the last edition. Also, they add a requirement of both clonality and abnormal bone marrow morphology of megakaryocyte and erythroid dysplasia. And this is raising a big question mark as why they didn't include the chronic eosinophilic leukemia under the MDS MPN, since that we have a dysplastic clone in the bone marrow or peripheral blood. And they eliminate the increased blast that previously stated as alternating to clonality. And now we don't need to say that this is chronic eosinophilic leukemia NOS anymore. It's just stated chronic eosinophilic leukemia. They retained also the NOS MPN in this edition. For juvenile myelomonocytic leukemia, as I told you before, that they categorize it now under MPN, so it's considered as an MPN of child age and adolescence of less than 18 years. They updated the diagnostic criteria, so they exclude the KMT. We need to exclude the presence of KMT2A, or previously called MLLG rearrangement. They eliminated the monosomy 7 from the cytogenetic criteria, and they emphasize more on the significance of diagnostic molecular studies, particularly presence of RAS pathways activations. For myelodysplastic syndrome, now they name it as myelodysplastic neoplasms, but the abbreviation is kept MDS. This is just to, they are saying that they call it neoplasm to go and align with other neoplasms as MPN, and also to stress more on the malignant and neoplastic pathogenesis on the disease, rather than that it's a syndrome that may lead later on to malignancy. They defined the cytopenias, and they harmonize it with other cytopenias in the clonal cytopenia of undetermined significance or other cases of NDS-MPN. So they define anemia now of less than 13 for males, less than 12 for females, the neutropenia to be less than 1.8, and the thrombocytopenia of less than 150. However, you need to confirm that the patient have morphological abnormality in the bone marrow or dysplastic changes in the bone marrow and peripheral blood. They kept the threshold of dysplasia 10% as a previous edition. This is the classification, the new classification and defining feature of myelodysplastic neoplasms. Now they categorize the MDS into two groups. The MDS with defining genetic abnormalities. We have 3 subtypes of MDS with a 5q deletion, and the criteria is similar to the last edition. And we have the MDS with low blast and SF3B1 mutation when the patient have ring sideroblastosis anemia. And we have also the subtype of MDS with biallelic TP53 inactivations, or what's called multi-hit TP53 in the ICC. So those patients should be regarded as AML in treatment, as they are showing a very poor prognosis. The patient usually presented with a complex karyotype, and you need to confirm that those patients have more than one TP53 mutation, because this is a tumor suppressant. It's not an oncogene mutations, so you need more than one mutations. For example, if you have a variant allele fraction of more than 50%, you should consider that this patient have more than one hit of mutation. The other subgroup is MDS with morphologically defined. Now, it's optional if you would like to call it multi-lineage dysplasia or unilineage dysplasia by morphology. However, you can consider them both of the two under the low blast MDS. They added the hypoplastic MDS as a separate type, and they define it as presence of less than 25% age-adjusted bone marrow cellularity in the trifine biopsy. The excessive blast, now they call it increased blast, so MDS with increased blast. We have MDS increased blast 1 and 2, and we have also the MDS with fibrosis. The percentage of blast or presence of our rod is similar to the last edition. They still accepted the term of MDS with low blasts and ring sideroblastosis if we have a wild type SF3B1 mutation and more than 15% ring sideroblast. And as I told you, they considered the biallelic or multi-hit TP53 MDS to be regarded as AML equivalent in therapeutic considerations. They accepted the multi-lineage and single lineage morphological description if you would like to add it in the diagnosis. However, they removed the MDS unclassifiable from the 5th edition classification. For the MDS and AML definitions, they still retain the 20% cutoff for diagnosis of AML. And I would totally understand. They add a very nice discussion about this topic in the paper, saying that we don't have a gold standard methodology for quantification of the blasts, enumeration of the blast, except the pathologist manual counting. And still we have variation and subjectivity in that matter. Flow cytometry always, in the cases of MDS, will give a lower threshold of enumeration in comparison to the pathologist counting, and also adding that most of the cases of MDS will have hypocellular hypocellular aspirates, so maybe you will underestimate the presence of a blast morphologically. And last but not the least, that they would like to avoid over-treating patients in cases that we call them MDS AML, especially for increased blast to MDS. However, there is a broad agreement that MDS increased blast to, or what we called previously excessive blast to, that should be regarded as a case of MBL equivalent in therapeutic consideration. For childhood myelodysplastic syndrome, it's what's previously called refractory cytopenia of childhood. There is some update in the terminology. So now we have childhood MDS with low blast and increased blast. And in the low blast, we have a hypocellular childhood MDS with low blast and NOS. And the biological landscape between the increased blast and low blast in the pediatric MDS or childhood MDS is similar, but it's totally different from the biological or genetic landscape of MDS of adult, saying that this is totally a different pathogenesis from adults. MDS, MPN neoplasms, there is a major revision in the diagnostic criteria of CMML. The change also in the terminology of MDS, MPN. The other diagnostic criteria for other type didn't change much. They renamed the atypical CML into MDS MPN with neutrophilia. This is one of my favorite changes because the former naming is very misleading, saying that this is atypical CML. However, it's totally different from a CML case. Also, they renamed the MDS MPN with ring sideroblastosis and thrombocytosis to be MDS MPN with SF3B1 mutation and thrombocytosis. And also then unclassifiable become now NOS. Regarding the CMML criteria of diagnosis, one of the major change is that reduce the cutoff of absolute monocytosis and lowered from 1 to 0.5, and this will include the cases of monocytic CMML. And to avoid misdiagnosis of CMML, they are saying if you have a cases of less than 1 monocytosis but more than 0.5, you need at least number 1 and number 2 supporting criteria. So in the criteria, we have a prerequisite criteria of monocytosis less than 20% blast, not meeting any criteria of MPN or CMML, and not meeting any criteria for other tyrosine kinase fusion, myeloid lymphoid neoplasm with eosinophilia. They are adding one supporting criteria, which is abnormal partitioning of peripheral blood monocyte subset. This is a flow cytometry analysis for the peripheral blood monocytes. It's well known that monocytes have 3 stages of expression. So we have the classical M1, intermediate M2, and non-classical M3. So in this study of CD16 and CD14, in the cases of CMML, you will find that most of the monocytes retained on the classical monocytes 1 stage of more than 94% of the monocytes in the peripheral blood. However, in cases of other monocytosis due to reactive or MPN, you will find that there is a good number of monocytes landing in the intermediate and non-classical stage of monocytes. So presence of more than 94% monocytes in the classical stage, this could be considered as supportive criteria for diagnosis of CMML. Still, we have the myelodysplastic CMML and myeloproliferative CMML if the white blood cell is more than 13, and they eliminated the CMML 0 as it's not adding any diagnostic implication. So we have only now CMML 1 and CMML 2 with similar percentage as previous edition. For acute myeloid leukemia, one of the major changes that they eliminated the 20% plus requirement for all the types of acute myeloid leukemia with defining genetic abnormalities. So, except for cases of AML with BCR-APL1 and AML with CEPPA, and this is just to not overlap between the cases of CML on blast phase and the AML with BCR-APL fusion, and the other one is AML with CBBA, as there is no enough evidence in the literatures about eliminating the 20% blast, maybe in the future, but not until this release of this edition. Still, we have acute myeloid leukemia with myelodysplasia related, what we called before AML MRC. And we have also a big basket of subtype AML with other defining genetic alterations. It's for any new mutation that may be found and or number of cases found carrying the same mutations, and thinking that maybe in the future could be considered as defined genetic abnormalities. The previous term of acute myeloid leukemia, NOS, is now changed to be acute myeloid leukemia defined by differentiation. For AML with MDS related change, as I told you that it's called now AML with myelodysplasia related, the change in this category, they removed the morphology alone to make a diagnosis of AML myelodysplasia related. You need a history of MDS, you need a specific cytogenetic abnormality or defining somatic mutations. And now they updated the cytogenetic abnormality, and also they added 8 somatic mutations that's found undefined in the cases of MDS and MDS-MPN, and maybe lead to secondary AML for those cases. For AML defined by differentiation, we still have the 8 subtypes. They changed the name of pure erythroid leukemia into acute erythroid leukemia. This is a very nice table showing the different and diagnostic criteria for all the 8. They shared presence of more than 20% plus, and they are not meeting the criteria for diagnosis of MPAL or myeloid neoplasm post-cytotoxic therapy, or no history of MPN, and also they are not meeting the defining genetic alterations for recurrent cytogenetic abnormality. Of course, the presence of the 20% blast is not applicable for the cases of acute erythroid leukemia, because you need the pro-erythroblast equivalent more than 30% and more than 80% erythropoiesis in the bone marrow. We have now a new category of secondary myeloid neoplasm, is that any acute myeloid leukemia, MDS or MDS-MPN that arise secondary to exposure to cytotoxic therapy or germline predispositions. Now the therapy-related myeloid neoplasm renamed into myeloid neoplasm post-cytotoxic therapy. And we should exclude any cases of AML that's transformed from MPN, so this will be still under the MPN category as a blast phase, and any AML post MDS or MDS MPN, again it's kept under the AML post AML myelodysplasia related neoplasm. So it's not considered as secondary myeloid neoplasm. They included the exposure into PARP1 inhibitor as a qualified criteria for cases of post-cytotoxic therapy. They removed and excluded the methotrexate, and they recommend that if we can specify the type of leukemia, then we can add the appendix of post-cytotoxic therapy. For example, we can call the case as an AML with KMT2A rearrangement post-cytotoxic therapy. طبعا of course if there is a history and of previous exposure to cytotoxic therapy. The myeloid neoplasm associated with germline predisposition, there is no much change in this category. They just expand and add more onto variant. For example, they add the germline TB53 variant, and also they add the other germline SAMD9. They removed the GMML from the myeloid neoplasm with germline predisposition and potential organ dysfunctions. However, the clinical subtypes, the 3 subtypes, didn't change, and much of the variant are similar to the previous one, or the previous edition. Myeloid lymphoid neoplasm with eosinophilia and rearrangement of BDGFR alpha, beta, FGFR1, and BCM1, JAK2, they rename it to be myeloid lymphoid neoplasm with eosinophilia and tyrosine kinase gene fusion. And they added and recognized 3 more novel types with JAK rearrangement, saying that there is more than fusion gene rather than BCM1. So they call it just a JAK rearrangement, FLT3 rearrangement, and ATV6AB1 fusion gene, but we need also to differentiate between this subcategory and BLL with ATV APL1 fusion gene. And they also add other defined tyrosine kinase fusion that been reported before in this category. Acute leukemias of mixed or ambiguous lineage, now they define it based on genetic abnormality. As before, we have the BCR-ABL fusion and we have the KMT2A rearrangement. They added 2 subtypes. First one is the mixed phenotype acute leukemia ZNF384 rearrangement. Usually those patients present with immunophenotype of myeloid, B-myeloid immunophenotyping, and they present in more than 50% of the cases of mixed phenotype acute leukemia of pediatric age group. The next one is acute leukemia of ambiguous lineage with BCL11B rearrangement. It's have more heterogeneous immunophenotyping. It's been reported with a case of undifferentiated leukemia with minimally differentiated acute myeloid leukemia with early T precursor acute lymphoblastic leukemia. So it doesn't have a specific immunophenotyping for these mutations. And presence of the mutation in different subtype of immunophenotype lineage, giving us an idea that maybe there is a biological continuum between those types of diseases that could be discovered in the future. The other subtypes is acute leukemia of ambiguous lineage, immunophenotypically defined. Still we have the B-myeloid, T-myeloid, and rare types of BT or BT myeloid immunophenotype. Still we have NOS and acute undifferentiated leukemia. I believe this is my last slides. It's about how we diagnose the cases of mixed phenotype acute leukemia. The immunophenotypic criteria are majorly revised in these subtypes. Now they are dependent on the intensity and pattern of expression and coordinate a pattern of expression of multiple antigen from the same lineage. It's not about positivity and negativity of the antigens anymore. Saying that, for example, if you have expression of myeloperoxidase and the expression is more variable and similar to early myeloid differentiation of neutrophils, this will go more into or strongly into lineage assignment of the myeloid lineage, because that presence of DEM unified expression is not as it should be in the cases of normal myeloid progenitors. And in case of presence of coordinate patterns of antigen, for example, presence of CD19 together with CD10 and 22, this will give you a strong belief that this is a B lymphoid lineage rather than single expression of single antigen. So presence of multiple antigen from the same lineage is more going with the lineage assignment of that type. Still, we have for the B lineage assignment, if you have a strong CD19, you need one strong expression of 1022-79A. If you have a weak 19, then you need a 2 or more strongly expressed 1022 or 79A. For T lineage, you need cytoplasmic or service CD3. However, the intensity in part should exceed a 50% of mature T cells level by flow cytometry. Or if you are going to use the immunohistochemistry, you need to make sure that this is not a bully clonal CD3 because it may stain other than zeta chain reagent. So you need a stain of epsilon, not a zeta chain reagent. And as I told you about the myeloperoxidase for myeloid lineage, you need either presence of MPO or monocytic differentiation markers. For MPO, you need an intensity in a part exceeding 50% of mature neutrophils. And for monocytic differentiation, you need 2 or more expressing of non-specific esterase CD11C, 14, or 64, and it's almost similar to the previous edition. This is not the end, but I think we should expect more to come from the publishing of the WHO. Hopefully, it will be released on December, as they are saying, and it will explain more about some of the area that been confusing and not clear from this paper. Thank you.